Cartmel, and I'm the head of the Department of Materials, and I sit within the Faculty in Science and Engineering at the University of Manchester. It gives me great pleasure today to welcome you to our Manchester Institute for Collaborative Research on Ageing at the University of Manchester seminar series. We do have monthly seminars in our MICRA institutes that most of you will be familiar with, and we have our topic today that you can see here in the slide in front of you, which is the role of technologies for the well-being of older population. Just before we go to our speakers, I've got a few slides to introduce MICRA to you, the Manchester Institute for Collaborative Research on Ageing. But before I do that, just a few housekeeping notes. Just remind everyone to keep muted and your cameras turned off. We are going to be recording, and you can probably see that already, recording this session, and we'll be sharing this on the School Social Sciences YouTube channel. So please do keep yourself muted and the camera off for those purposes. We will be taking questions for our speakers today, but we're going to take those questions right at the end of the session when all three presenters have spoken. So please do submit your questions in the chat function, and please do direct your question to which presenter. So just put the presenter name and then put your question in. So when I'm chairing that session at the end of the presentations, I'll know who to direct that question to. So most of you be familiar that if you're familiar with MICRA, the main goals, but those of you who are not, the whole role of the Institute is the following that you can see here. So it's about advancing knowledge through ageing, through the pursuit of high quality research, and that's across the three faculties, and I'll demonstrate that to you in the next few slides. We want to also build research capacity in ageing across the university, and also enable translation of that research into the wider knowledge exchange, and also transform public and professional perceptions of ageing. And of course, we want to engage with older people and organisations and work on their behalf. Just to give you an example of some of those topic areas, so we have been able to identify 3 themes and 11 overlapping subject areas that you can see here. So we have our 3 themes of biological ageing, ageing in health, and social ageing, and in there you can see the different areas such as skin ageing, dementia that you can see, sensory impairment, biological mechanism of ageing, and then you can read through obviously those other 11 areas on the slide. So there's quite a lot of activity in MICRA already. Just to demonstrate what we've been doing in this area. So MICRA was established in 2010, and as I mentioned, the 11 areas are on the left-hand side, and you can see we've done this bit of a diagram just to show where we have our ageing research and actually the number of PIs. So what you see here, so there's 6, 26, 37. So a PI is a principal investigator, essentially a lead researcher, which then has a lead team with PhDs and postdoctoral research associates within their group. And then, of course, the amount of funding that you can see in the particular topic areas. So obviously, dementia, public health and ageing, and biological mechanisms, sensory impairment are leading in this area. So we have ageing research just under 42 million up to 2017. And in terms of where we influence that, so MICRA is affiliated to just under half of that. So over 20 million has been affiliated in this area with MICRA, and it's growing. So since 2017, when we had that data, obviously we're growing still. We're cross-faculty institutional network, and you can see that demonstrated from this seminar that we're hosting today, where we have presenters from cross-faculties. And that's really to support our interdisciplinary approach to ageing research. We have a team that's helping to support this activities. We have a director, deputy, we have cross-faculty management committee across the whole university, and we have over 300 affiliated researchers within the University of Manchester to MICRA. And we've been growing since I showed you data up to 2017, but up to June 2020, we had 130 new grants that have been awarded involving MICRA members. And of course, we've been establishing new and building on existing international collaborations with both European and North American universities. And we have a strong emphasis on sociological aspects of ageing regarding to class, ethnicity and gender. So coming back to our seminar that we're giving today. So again, I mentioned right at the start, our topic is the role of technologies for the well-being of older population. And just to give you an overview of the activity, separate from our seminars that you'll see today, of this area. This is just the tip of the iceberg. So this is just examples. So in our Faculty of Biology, Medicine and Health, so FBMH here, examples as a healthy aging and research group, where they have a gerontology research focus on mobile phones, ICT-based mobile health systems of residential care. In particular, they have development and testing for exergaming. So this is gamified tele-rehabilitation technologies and novel detector systems for use in hospitals and long-stay care. In the School of Health Sciences, there's this app that they're developing called the Manchester Digital Pain Mannequin app. And in particular, this is an intuitive way for people to self-report the location of their pain compared to questionnaires. And the developers of this app expect that this will make it easier for people to report their pain over longer periods of time, and such have a huge impact in this area. In humanities, a couple of things just to note. So we have this in the Global Development Institute, we have Smart Health Primary Care Intervention. And this is really for cardiovascular risk management in Malang in Indonesia. And this is development of a new intervention, as you can see there, called Smart Health, which provides village health workers, locally known as CADA, with training on blood sample collection. And a smartphone is then used to aid assessment and data collection alongside specific cardiovascular care guidance. I've already talked to you about MICRA and what we are, but within MICRA, we've specifically led a literature review for Ambition for Aging on the use of information and communication technologies to support social connections for older people. And then in my faculty, which is the Faculty of Science and Engineering, lots of activity, but just a couple that I've pulled out here. Tripoli is one of our departments, which is electrical and electronic engineering, where Krikor was going to be actually talking today. He couldn't make it today, but he has sensor technology for health monitoring in floor gate analysis. So this is very exciting because as your health changes, as you age or as you become ill, if somebody has an infection, for example, or if somebody suffers from mental health activities, their gait changes. And he's developed sensor technology, which is pressure sensors within the floor that can monitor these sensitive changes and actually give an indication of somebody not suffering from, but basically suffering from poor well-being quite quickly just from their gait. And you'll see a touch on some of this area in terms of what we do in the Department of Materials, where we have a fashion business technology group of researchers really looking at sort of clothing and fashion choices available for different generations and its impact on well-being, and how a lot of the design has been for the younger generation and actually how that's impacting for the older generation. You'll see a little bit of that from Rosie Boardman today. So my last slide, I think what I have here is just to introduce our speakers. So we have 3 speakers today. Each of them will talk to you just over about 10 minutes on the research. And then, as I say, at the end, we'll have time for some questions. I'll just give you a bit of information about what they're going to be telling you about before I hand over to them for speaking first. So Dr. Helen Hawley-Haig is going to be presenting on the development, usability and feasibility of smart phone apps to support falls rehabilitation against community dwelling and older adults. And this is called the Together trial. Mr. Musafi Ali is going to be presenting on engagement with consumer smartwatches for tracking systems. So it's called Watch Your Steps, and it's a prospective observational smartwatch study conducted by the University of Manchester in partnership with Google Fit Research, and you'll hear more about that shortly. And then our final speaker, Rosie Boardman, Dr. Rosie Boardman, again, as I mentioned, from my department in the Department of Materials, is going to be presenting her research into online shopping for older people, where an increasing number of older users are now shopping online, and as a result, the digital divide is decreasing. However, existing research is often based on younger users and student samples. Thus, research needs to address whether older users behave differently to younger users when shopping online, and whether current website designs are excluding older users. So I would like to introduce my first speaker, and Dr. Helen Hawley-Haig is our first speaker, and let me just give you a little bit of information about her. So she is a research fellow in the Healthy Aging Research Group at the University of Manchester. Helen obtained her PhD from the University of Manchester in 2011, and her work focused on older adults' uptake and adherence to exercise classes and the role of the exercise instructor. She's worked both in public health and in research looking at falls and fracture identification and prevention, and prevention for falls for patients. She was awarded the MRC Sanctuary Award in 2012 to further develop her PhD work as a postdoctoral researcher, and looked at the delivery of evidence-based strength and balance exercise programs in practice. She was the Research Associate and Communication Dissemination Manager for the Far Seeing Project, and led the work on taxonomy on behaviour change and attitudes toward this technology, including advising on the design of the technology so as to encourage older people's engagement with it. It gives me great pleasure to welcome Dr. Helen Hawley-Haig, and I'll hand over now for her presentation.
My name is Dr. Helen Hawley-Haig, and I'm going to talk to you about some work that we've been doing to develop smartphone technology to support home exercise for falls rehabilitation. And the end product has been the Together trial, feasibility trial. So we have really good evidence that strength and balance exercises in particular help reduce falls, prevent falls, reduce the rate of falls, and also injury from falls, from a number of Cochrane reviews. But we're not actually very good at implementing this evidence base. NHS services tend to only see older adults once a week, and there's a dose response related to falls. So we know that patients should really ideally be doing their exercises 3 times a week. So we rely on home exercise, and older adults are not very good at doing their exercises at home, which I don't think any of us are, and also not very good at keeping them up, which they need to. So dose is really important, as also progression of exercises so that they continue to be challenging. So in response to this, working closely with older adult patients and health professionals, we developed 2 apps. So the original plan was it would be 1 app, and then based on feedback at very early stages, we actually ended up creating 2 apps, one for the health professional and one for the patient, that speak to each other. So the health professional app is called Motivate Me, and this is used by the health professional with the patient to set their goals. So what is it that they want to achieve and they want to be able to do that they can't do now, or what would they like to be improved? And this is underpinned by behaviour or change theory. So we know, particularly for rehab, that setting goals is really important to patient expectations of what they're going to get out of their exercises. And also patients set behavioural goals, so they plan with the health professional when they're going to do their exercises and what they're going to do, and it's personalised to them. The health professional then sets the patient's programme, then the patient can see in their own phone, in their own app, and uses the app to assess what the patient is reporting about their exercises and see what exercises they've been doing and when, and also to give them bespoke feedback. So in the study, in the final feasibility trial, we asked the health professional to send the patient a personal message once a week. This is just an example of one that I sent to my mum when she was using it in lockdown. And then the patient app is called My Activity Programme. And again, the wording of this is based on patient feedback. And the patient can use the app to report the exercises that they've done, because we know, for example, that sensors in phones are not reliable enough for static strength and balance recording. They can receive prompts when they're scheduled to exercise. They receive automated messages based on their goals. But they also receive this bespoke feedback from the health professional once a week. And for more details, we have published the development papers on the development of the app. So the idea was that the technology would increase the patient's exercise by giving them some social support and communication with the health professional between when they saw them. Sometimes they might only see them once a month. And that the behavioural support, the communication, and the prompts and reminders would help to support them to engage in their exercise. So it's been a long kind of term project, really, in terms of we did some very initial kind of conversations and developing ideas and developing the goals and developing feedback, both with exercise instructors with this qualification to deliver, health professionals, older adults, and patients who've been through 4 services. We then did some usability testing with one service in Manchester, where we looked at the acceptability and usability of a prototype, and we recorded any issues, and we also did interviews with patients. And funnily enough, actually, as part of the study, we also tested teleconferencing for the delivery of rehab, and this was long before COVID, actually, in 2016. It's an iterative process, so we then reflected on the findings from that and made some amendments to the prototype, and we then set up some revisions, and then we went forward to the feasibility trial, which is aimed at looking at the feasibility of the intervention within practice. So it was health professionals that would be using it. So standard service, whatever they normally deliver, versus standard service plus the smartphone apps. Assess the feasibility and acceptability of the approach. Could we recruit enough patients, and have we got the right outcome measures, and what was our dropout levels like? And also we looked at key differences across the outcome measures so that we can potentially look at effect sizes and whether it's worth going forward to a full study. So we approached 136 participants for us to take part. We actually did this across 5 sites, although some of the sites we got on board very late in the day when we realised we weren't quite recruiting as fast as we wanted to. And overall, we ended up recruiting 50 patients, quite evenly distributed into the control and intervention arm. It does look a bit messy, and I think that's because we very much wanted to represent the patients that go through the services. So we didn't necessarily exclude people with dementia. They had to have some sort of support mechanism to help them, but we didn't exclude people with dementia, and we didn't exclude people with certain conditions, because lots of us have complex conditions. And so as a result, we did have quite a high level of ill health, and we did have some loss to follow up, but we actually only lost one person completely out of the study who didn't fill any of the outcome measures. But we did lose some of the physical outcome measures towards the end of the study because of the COVID-19 pandemic. And we had, just moved that up there, quite a good age range between 62 to 92. Quite a large number of the participants were female, and but not all. We had good representation of male, and quite a large number were white British, but we did get some representation of different ethnicities as well, particularly recruiting in central Manchester. We did find that it was feasible. We recruited enough eligible participants, although recruitment was slower than we expected. 77% in the intervention group completed their full exercise programme, including using the app. So most people who didn't, it was because they were told to stop rehab because of ill health or uncontrolled health conditions. A large number provided a balanced measure at 6 months, despite the fact that we lost some to final follow-up for COVID. It would have been willing. Only one participant actually withdrew from using the app. There was a large amount of hospital admissions and acute illnesses, which is really important for us to take in consideration in the full trial. And thankfully, there were no serious adverse effects events linked to the intervention. When looking at the outcome measures, obviously, there's not enough numbers there to say anything it's significant, but there were differences in that the intervention group did do better for some of our main outcome measures around balance and around falls. So there were less injurious falls in the intervention group and less number of falls in the intervention group. And adherence was mixed. So we collected adherence through questionnaires, and we found that adherence was really good at 3 months, and it sort of tailed off over 6 months. It was a very pragmatic study, so the intervention was different in terms of different services. And one of these services, which was about half the participants, stopped, only did the intervention for active physiotherapy for 8 weeks. And so after the 8 weeks, they were discharged and they continued to use the app. But they knew the health professional wasn't at the other end. So we wonder if that kind of affected the adherence rates. Also, we did obviously get people who weren't actually allowed to do the exercise because they've got uncontrolled medical conditions that still actually completed the form. But all outcomes did look promising, and obviously with a small number of people, it's hard to say anything strongly. Strength, function, and was better in the intervention group, and fear of falling did go up in both groups, which is actually quite normal for these kind of interventions because you're challenging people to balance more. But then was lower in the intervention group at 6 months. And we did find, we collected data for health economics, and we did find that the intervention group saved health resource use and costs, obviously a small number. It wasn't all cupcakes and roses, so we used some digital outcome measures alongside the apps, and the falls detector and self-report app in the control group did not work particularly well. Patients across both arms forgot to wear the phone in terms of the falls detector and found it inconvenient and uncomfortable. Where they've got their own phone already, they forgot to, they moaned about carrying it about, and where they didn't have a phone already, they often forgot to wear it. We did have some issues with false alarms from the falls detector. And we did find, although some people in the control arm, we asked them to report their exercises, but they got nothing else. Found that motivating most because they weren't getting anything back from the phone, forgot to report their exercises and just left the phone on the side. So in terms of an outcome measure, it was not that successful. So what did patients say about it? Well, there are, it's better to hear from them, and we've got a video with some of the patients talking about the apps, but they did really like it. Most patients really liked it. Goals were really important to the patients. They liked the additional support that they got. They felt that it made them they were looked after. One even called it the physio on their shoulder, that they felt like they were always supported by somebody. Personal messages were particularly appreciated, and health professionals particularly liked seeing the impact that it had on patients. But do go and have a look at the video. Just to say that 40% of our patients had got a smartphone and used one before. About 45% in total had one, but a few had one and didn't really know how to use it. So we did give out smartphones and did find that they could use them if we gave them the right support, and obviously we developed the apps with them. So there are some changes we want to make. Patients said that they missed messages at times, and we found that in the original testing. So they had to say, I like it, or they didn't like it, basically, when the messages came up. But sometimes they'd just knock the touch screen and close the apps completely. So we thought we'd create a message centre for the patients, the messages from the health professional, and also see if the app could resend the messages when they were more likely to look at it. So some patients definitely got in habits of when they would be more engaged with the phone. They would like to send health professionals messages. For example, when they report their exercises, they'd like to say if one's causing them discomfort or pain and they can't do it. And the health professional thought that would be really useful because they could maybe prescribe them alternative if they knew. But they were quite worried about them being able to send free text messages to them whenever they wanted, and their expectations and the capacity to be able to respond. So that's something we need to explore further. And where patients had their own phone, they would much prefer to use their own. So we gave them all phones, partly because of the falls detector and the requirements of the phone for that. But this only works on Android at the moment. So we'll be looking to create a version that works across all platforms. And just want to say thank you, and specifically to George Street, who was 97 and was one of my participants who took part in the first development studies, and helped me to recruit patients to the feasibility study. When they said they might be too old to use it, I would take George and he would show them. And he'd never used one before he started working with me. And unfortunately, we lost him in the summer. So I just want to say a big thank you to him and everybody else involved.
Many thanks indeed, Helen, for doing that recording for us and playing it. Just to know, to have put that into the chat as well. Helen isn't very well, but she has actually joined us live to take questions at the end, but that's why she did a recording. So thank you for your time, Helen, and your stoicism. We'll pass on to our second speaker. As I mentioned before, Mr. Syed Mustafa Ali is going to be speaking to us next. He is a research assistant in the health informatics at the Centre for Epidemiology versus Arthritis at the University of Manchester. Before joining the centre, he designed, monitored and evaluated public health initiatives, particularly in tuberculosis and reproductive health in Pakistan for more than 10 years. At the centre, he focuses on digital collection of patient-generated health data. As a continuation of his past work on reducing health inequalities, he aims to harness digital patient-generated data to improve the health outcomes of culturally diverse populations. He took and was awarded a Masters of Public Health in the University of Liverpool in 2020, and in 2015 he was awarded a Master in Science, Leadership and Management in Health and Social Care at the University of Southampton. It's a great pleasure to welcome you to come and speak to us today, and I'll hand over to you now, Syed. Thank you.
Thank you, Sarah, for the introduction, and thanks for having me here. So I'm going to talk about Watch Your Step. This is the feasibility study that we conducted in collaboration with the Google Fit research team at the Google. So we have used smartwatch to track daily symptoms for individuals living with multimorbidity. So multimorbidity, that it means that a person is living with more than one long-term condition at the same time. And there are estimates telling us that there are 24% of the UK population are living with multiple long-term conditions, and 54% of over 65. So that's a projected. In 2015, there were 54% of over 65 people living with multiple long-term conditions, which is projected to increase in 2035 by 68%, which is huge. So that suggests that there's a huge burden on people because they are having multiple long-term conditions, and 1 in 3 urgent hospital admissions have more than 5 long-term conditions. So this was information that guided us that why multimorbidity has become an important subject to study. And there are few important publications in this regard, and that why it is a research priority. So despite the huge problems multimorbidity brings, there is surprisingly little research into its impacts on patients and healthcare system and society at large. So and it's also important to know that what kind of conditions people are suffering from and how they interact with each other, so that we know what kind of mix of conditions they have and how the symptoms of each conditions they interact with each other. And in the same regard, there's another important publication so that suggested how these has become a research priority. And in that publication, they have identified that why digital epidemiology or the remote monitoring has a potential to try to solve this problem, because at the moment the issue is there's lack of or less understanding on how things are changing with people who are living with multiple long-term conditions. And there's also a need to develop measures to collect, link, and share appropriate data and outcomes for multimorbidity, particularly focusing on longitudinal aspects, including continuous disease monitoring, because I mean that's also important. Most of the studies you found, they are cross-sectional and they give you enough information about the person. So collecting these measures over the longer period of time had a potential to provide a sufficient knowledge about the multimorbidity. And so we have seen that consumer devices have been used for health, and that number is constantly increasing. And these consumer devices are not only used for self-management, but also for clinical care and for population health research. And when we look at the smartwatch as a consumer device, so we see that in theory you can self-report data via touch screen, and you can collect continuously passive sensor data from the smartwatch, and you can provide feedback through the watch face. So in this smartwatch feasibility study, we looked at the engagement patterns through time, and we also try to see how the symptom patterns change over time, so that we can see what's changing in their daily data. So this is a prospective observation study that we ran, for which data collection ran for about 90 days, and we asked daily questions multiple times in a day. And we recruited participants from clinical settings and from PPI groups, and participants were people who were living with multiple long-term conditions. And those who were eligible, we gave them Fossil Sport smartwatch with this data collection app already loaded on that. So this is the way the question was asked on their watch face, and there were two ways they recorded their response: by using this radial scale, and also through going through the list and picking one option out of many. And so this is the typical case. So here we are taking an example of a participant who is suffering from joint condition and a heart condition. So you see here core symptom questions. So everyone, regardless of their long-term conditions, they were asked these 7 questions at different time of points in a day. And they were also asked to complete active tasks. So there were these 3 tasks were asked once in a week. And these joint condition related questions were also asked. So I have given what you can see here, though people are having multiple long-term condition, they are having burden of disease. So they were asked about, on average, 20 questions a day. So I have already shown you how easy or how quick it was to answer those questions. But anyways, about 20 questions or about 150 questions in a week for a typical participant. And how we actually calculated the completion rate. So for example, if there are 20 questions asked, and out of those 20 questions, if they have answered 10 questions, that means the completion rate for that particular day was 50%. And that's how we have calculated completion rate for each day for each participant. So completion rate was number of completed tasks for that particular day and the task out of the task schedule. And we only considered those responses which we received within the time bracket. So for example, for a daily question, there was a time window of 3 hours for which that question will remain active on the watch. So you have to answer that question within that window. But you were still given that option to go into the app menu and answer that question if you want to do it at any point of time. And then, so for showing the patterns, how symptoms change over time, I will show that through smoothed trend lines, smoothed patterns. So I will show that later on. So 53 participants took part in the study, and almost half of them were male and half were aged between 50 and 69. And the majority of them, despite the data collection burden, we are asking about 20 questions per day. Most of them, majority of them provided the data throughout the study, although sometimes at low rates and at sporadic intervals. So if you see here, so you will see age groups here, 18, 29, 30, and this. And these, through this ridge plot, you can see the number of questions answered per day. So if, for example, it is yellow and it is touching the above line, that means the completion rate for that day was almost nearly complete. I mean, 20 out of 20 questions were answered. And if you particularly look at those in 60, 69, and 70, 79 age group, you can see their completion rate. They look better than other groups. And these are the additional tasks. So additional tasks were those when you have answered the questions by going into the app menu and answering those questions. And you would see, so these are 53 participants, each dot represent one participant, and you will see there were people answering about 100 additional questions over 90 days period. And even there were people who answered more than 1,000 questions during that 90 period. And in terms of checking the feasibility of asking the question, we found that at 8 p.m., whether the question was unprompted or prompted on the smartwatch. So 8 p.m. seems to be a feasible time when most of the questions were answered by most of the people. Now, talking in terms of completion rates, so the overall completion rate was about 45%. but it was highest among 70 and 79 people, and you can see people with age 70 and 79, and you can see the completion rate was about 73%. And if you look at this graph where you see ages here, gender, employment, and number of organs affected. So look at this. For 40 and 49, it's about 75% completion rate, but for people with 70 and 79 age group, in that age group, the completion rate was highest, as I told you before. In terms of gender, male had a higher completion rate than female, and employed had a higher completion rate than unemployed. And those who are having they have organ system affected more than three, they had about 50% of completion rate, better than those who are having less number of organs affected. So this is just an example to illustrate that how through the smartwatch we were able to capture the volatility and stability of the symptoms, how they vary across time. So if you see here, like if fatigue is, so fatigue 0 is best, pain level 0 is best, and mood 0 is worst. So if you look at the example B here, so mood here is good or better, which is indicated through this nearly straight line in graph B, while the symptom for fatigue and pain, they were better too. So it was relatively stable case. And if you look at A example, so you would see that how these three symptoms vary across time. And if so for example, if pain here, if it is if you have less pain, then you have a better mood. And when your pain is increasing, then your mood is worsening. So this is the kind of variations we were able to capture through. I'm sorry about the background noise. I'm sorry about that. If you're able to hear it. Here you can see that we were able to capture the variance among the participants and the symptoms that were changing over time. So what we found from this study that smartwatch is a feasible tool for collecting daily multiple symptoms from individual living with multimorbidity, and mainly because of the reason that these consumer devices are integrated with the in the personal life. So if you use them for daily data collection, then there's a high potential that you can use them for this purpose. And also we were successful in capturing those symptoms variability, which otherwise will be missed when you are conducting a study which is cross-sectional or study with less number of occasions when data was collected. So here you can see day-to-day variations, which can be useful for future clinical practices or future research studies. So that's the study that we have conducted, and we found it's a feasible method to collect data from the people suffering from multiple long-term conditions. So thanks for listening.
Thank you, Mustafa. Fantastic presentation, really interesting work. I'm going to pass over to our final presenter today. So Dr. Rosie Boardman is a senior lecturer in fashion business within the Department of Materials at the University of Manchester. Rosie's research primarily focuses on digital strategy and innovation in the fashion retail industry. In particular, her research specialises in how technology can be used to make fashion retailing more inclusive, enhance the customer shopping experience across all age groups, and improve social and environmental sustainability. Rosie primarily uses eye tracking technology and qualitative research methods, and she has published several peer-reviewed academic papers in world-leading journals, as well as 2 books. Rosie, over to you. Thank you.
Thank you, Sarah. Just share my screen. So can you see that okay, hopefully? So yeah, I'm delighted to be here today. Thanks for having me. So my presentation is going to be about creating more inclusive website designs for all age groups. So online shopping is now bigger than ever. It's grown steadily over the last 20 years, but because it's obviously very convenient, it saves travel costs and travel inconveniences, and there's a lot wider, broader product selection online. But the pandemic has accelerated this growth even further. So now more people are shopping online than ever. When we were in lockdowns, we obviously couldn't go to physical stores, so people that hadn't shopped online before started to shop online in 2020. So it has seen record sales in the last year and a half. But this just shows that, one, that the digital divide is decreasing, and you know, all age groups now are shopping online. And it highlights the importance for retailers to have effective website designs and to have inclusive online shopping offerings. So the goal of a retail website is to support customers, to help them make informed decisions about the products that they're buying, and also for it to be a pleasurable experience. Lots of people like to shop online for fun, so it should be something that's enjoyable, and also for retailers, they want that to be the case so that they will return to that website. However, the problem is that retail websites are often designed for the convenience of the retailer rather than the consumer. So they're designed so that retailers can easily pull through data, you know, to find out which products are the most popular, how long people are spending on product pages, what the sales figures are, and so on. And the customer's experience with the website has been very much secondary. The other problem is that the research that has been done in website design primarily focuses on younger people, and often has student samples as participants. And so there's a very limited amount of research that looks at how older people might use websites and what their requirements might be for website designs. And so we want to see whether the results will be different for older age groups, and to see if websites can be designed in a way that's inclusive for everybody. So we had 50 participants in our study, aged from 20 to 70, and we worked with a retailer where they kindly allowed us access to their customers. And this was a retailer that had a very wide target market. So all customers of all ages from 20 to 70 actually shopped there. And they were all regular shoppers. They'd all bought something from the website in the last 3 months. This was important to us because we wanted to make sure that we spoke to people and observed the behaviour of people that, you know, actually did use the website, so that we could really get their insights into the website design. So we observed their behaviour using eye tracking technology, which allowed us to see exactly where they were looking on the website. And we also interviewed them for an hour afterwards and went through the website design and got all their insights, their thoughts, their feelings towards it, and how they felt that it could be improved. There was no time limit on either of the methods. You know, we wanted it to be as relaxed as possible, and also for it to be realistic. You know, we didn't want to say to someone, shop online for 5 minutes, because they'd be clock watching. We just said, behave as you normally would do, click on anything that you normally would do, to try and get the most realistic results. So for eye tracking analysis, one of the main ways that you can visualize your finding is through heat maps. So red areas show the areas of the web page that receive the most attention, then the orange and the yellow areas the second most attention, then the green areas the least attention, and then any areas that don't have any colour on it whatsoever did not receive any attention. So in terms of our findings, we did find that there were differences in behaviour for different age groups when they were shopping online. So you can see here on the home page, we've got the 20s heat map on the left and the 60s heat map on the right. So the 20s were very focused when they went on the website. As soon as they landed on the home page, it was about 2 seconds where they clicked off. They went straight up to that top left corner to select the product category that they wanted, and they didn't spend any time sort of looking around the home page really. In contrast, the 60s, they had a much more scattered viewing pattern. So here on the right, you can see the heat map. There's lots of different fixations everywhere. They're looking all around the page, and lots of the images around the page, and the flashing image in particular in the middle, was quite distracting from them. So in the interviews afterwards, they said that they wanted to do, you know, exactly what the 20s did and go to that top left-hand corner and select their product, the product category, but that there were lots of other things that kept distracting them and kind of holding them up. And as I said, the main culprit for this distraction was the flashing banner in the middle. So you can see on the right here, this is a gaze plot from one of the 60s, which shows where their attention was. So they're going back and forth from the menu, trying to select their product, but that flashing banner just kept drawing their eyes back to it. And this might not even be a conscious thing, you know, but that flashing nature just kept distracting them and then making them take longer to select their product category. Some of the interviews revealed, you know, they were saying things like, this confuses me a little bit, it's a bit too fast for me. Every time I want to go on it, it flashes over to the next one, and then I lose a bit of confidence. So it was also starting to have, you know, people that were new to shopping online in particular, or people that were still not as confident shopping online. When they kept getting distracted, it did have that impact on their confidence and that, you know, almost their self-esteem, thinking that it was more difficult shopping online than it should be. So this is something that, you know, obviously retailers targeting older age groups should bear in mind, that, you know, this was just, the flashing images was distracting and irritating. However, one thing that older users really did like to have was key information below the fold of the page on the home page. So, you know, when you're on the home page and you scroll down, generally you find information about returns, delivery, you know, sort of frequently asked questions, contact information. And this wasn't really important to the younger age groups. They never scrolled down and weren't really interested in trying to find this information. But it was something that was found to be reassuring for older age groups, that if they ever had a problem and they needed to get in contact with the retailer, that they knew that information to do that would be down there, and that it kind of gave them that reassurance and that confidence that everything would be all right. So it's important to include that for older ages. So when people click through to their product category and they were scrolling through the different products, we also found there to be differences. So you can see on the left, that's the 20s heat map. So when they were scrolling down, looking at the products, their attention was pretty consistent all the way down. They just looked at like quite a wide product selection, and anything that interested them, they focused more attention on. The 60s, on the other hand, the heat map on the left, you can see that there's a lot less fixations, a lot less green, red, orange in particular, the further down the product listing page they go. And we found that as older ages were scrolling down, their attention decreased. So they weren't paying as much attention to the products the further down they got as the ones that were nearer the top of the page. You can also see on the heat map on the right-hand side of the 60s that the most attention was actually on this menu bar that they used to filter their search. So this was really important to them, and they spent a lot of time selecting different things to make sure that the products that they viewed were specific to their needs. So things that were particularly important were size and very much length, so that people in the 50s and 60s wanted to choose to narrow down their search. So they wanted to have this more customized product selection, whereas younger ages were happy to just view everything and didn't really narrow down their selection at all. And so we found that in the interviews, people felt quite strongly about length in particular, and they wanted to, in the 60s, they wanted to make sure that they had the option of products to buy that would conceal more of their arms and their legs. And this just suggested that body perceptions change over time, and that people become more conservative in terms of the length of products when they get older. So things like capped sleeves, longer sleeves, on the knee or below the knee dresses and skirts were seen as quite important to shop for older consumers. And this, just one of the interview quotes from the 60s here, she just said, "It just helps me to do it very quickly, so it saves time. It's very helpful. That helps me to get something appropriate." So having that filter system on the left and being able to disregard all the products that didn't meet those requirements for them was very important. On the product page itself, we also found some differences. And in particular, we found that when the product was on the mannequin image, so there's that image of the garment on its own with no one wearing it, that was important for the 60s and over to include. So they found that quite helpful to just have a look at the product on its own and see what it looked like just hung up, whereas younger age groups didn't really like to see this image. So you can see on the left, the heat map of the 20s. On the mannequin image, it's very green, it was barely looked at all. They said things like, I'm not bothered about that one, I just want to see it on a model, whereas the 60s spent a bit more time studying it and did find that useful to include. We didn't find any differences between age groups in terms of their response to the model image. All age groups like to see clothes being shown on a model, and this is because they can see how it's worn, even if that model doesn't look like them or isn't their size or isn't their age. They still find it helpful to be on a person so that they could see how it hung and what it would look like. Although we did find that people would prefer to have models that were more reflective of their age and size as well. But it shows that it is really important for all age groups to include a model image. Also on the product page, we found a difference in people's response to product recommendations. So younger age groups, 50% of them looked at these product recommendations where you're on a product and the retailer says you might also like this and sort of recommend or suggest similar products or items that might go with it. This 50% of the 20s looked at it, but this increased significantly with age. So 90% of the 50s looked at the product's recommendations, and all of the 60s looked at product recommendations, and said that they just found this really helpful for inspiration and also for sort of cutting down their shopping experience. They liked the fact that if they were looking at something, the retailer acknowledged that, and then they said, oh, you might also like this. They found that to be quite helpful. So in conclusion, we found that age groups do behave differently on websites, and so retailers that target different age groups should design their website differently in order to make sure that they provide a good experience for their target market. In particular, we found that older age groups took longer to navigate the website and that had more attention on navigational features. So they spent longer sort of looking at the buttons and the menu selections and just making sure that they were the right things to press. Which suggests that maybe the current website design isn't as intuitive, and navigational features like those buttons, like the menu bars, just need to be nice and streamlined, clear, easy to use, and there not be lots of distractions on the page and unnecessary images where there were. In particular, not any flashing banners, because this was seen to be quite irritating and distracting. However, it is important to include that information below the fold of the homepage about delivery, returns, contact details, etc., because it's reassuring for older consumers. We also found that on the product listing page, older users' attention decreased as they scrolled down the page. So it's important to provide more concise product selections and product listings pages for older age groups so that the products retain their attention, and also have that filter system so that they can narrow it down themselves and have less products. So that filtering system, which includes things like size and particularly length, is really important for older age groups. It's important to have products shown on models for all age groups, but it's also important to have it on a mannequin for older age groups as well, much less so for younger users. And it's important to include product recommendations for inspiration for older users too, but it's also important for those product recommendations to be accurate. So some of the criticism from people was that the product recommendations didn't always match up. So, it's not something that retailers should just do for the sake of it. They need to have them correctly matching the garment that they're looking at. So all of these things should help to improve the customer experience for different age groups, and our research plan going forward is to look at this even further and interview and observe using eye tracking technology even older age groups, and also to test like these different website design suggestions to see if they do make a difference and if there's improvements that can be made further. So thank you. you very much. Just some of our papers there, and I'll pass back over to Sarah.
Thank you so much, Rosie. Really, really exciting work and really interesting. We have a few minutes left just before 12 o'clock, just for some questions. We've had some questions coming into the chat. I'd like to thank Dunhill Medical Trust, just to draw everyone's attention, if you can see that that you can see the chat, for the there's a report that's just been launched, the Technology for Asian Population Panel for Innovation. So please do follow that link if you are interested. We've had a query that's more generic rather than going straight to a panel member, but this is from Tony Johnson, asking what research is being undertaken to improve the productivity of NHS and social care staff. So I'm not too sure any of our panel members have the remit to answer that. I don't know if, Helen, you know if anybody in your group, because I don't know, maybe in the Healthy Ageing Research Group, you might be better placed to address. Do you have any input?
No, I'm afraid I don't in terms of productivity. I do know that because I've been doing a lot of work with the Chartered Society of Physiotherapy, and I know that post-pandemic they're looking at productivity and workforce, and how whether they've got enough workforce to deliver on the long-term plan that we're all working to. So I know that's been looked at, but no, I mean the research that we've been doing is, I guess, trying to enhance what's already done to get better outcomes, with very little additional time needed, but it's not particularly focused on productivity.
Thank you very much for your question, Tony. I wonder if you could drop an email to Suzanne Booth, who had organised the seminar. She's online as well. If you need her email address, do let us know. We could pop it into the chat, and she can take that away and get you a bit more information, just because it's not quite the remit of our panel today. But thank you for your question. We also have a question from Martin Mathfelder. Again, I think this is for, there's no specific speaker, so I wonder if any of the speakers, and I'll probably come to Mustafa first, just because we've heard from Helen, any socioeconomic data in any of these studies? Is that something that you've included?
I think for a very obvious reason, we didn't consider them, because this was a feasibility study and we wanted to keep the inclusion criteria broader, so we didn't consider them. Thank you. And Helen, is that something you've included?
Yeah, we have collected. So we haven't. We were targeting whoever the services saw. So I think, like Mustafa, we're very keen to represent the services. So because it was feasibility, we tried not to exclude people unless they'd got real problems with obviously vision to be able to use the phone. But we did recruit across different sites, and we recruited from central Manchester. So we did recruit people from deprived areas and different social economic areas, and we did collect data on home ownership and also education. But obviously, with it being a feasibility study, we've just presenting that as the demographics of our population rather than doing any separate analysis on it, because we haven't got enough participants.
Thank you very much. And we have a question from Chris Todd, I think directed for Rosie, who says, might practicality rather than look become more important with ageing? Covering up skin could be simply to stay warm. Do you have any comments, Rosie?
Yeah, thank you, Chris. That's a really good point, and I'm sure that's definitely true. It didn't come up in our interviews, but I think people were mainly talking about clothes from, you know, aesthetic purposes. So I'm sure if we did more research into that, it would probably come up. Yeah, I agree with it.
Thank you. Thank you to all our speakers today, and thank you to all the comments. And there's all the comments in the chat as well, but I think we've gone through all of the questions. We're just before 12, so rather than taking it, I've got lots of questions, I'm sure others do. Rather than move on and probably eat into your lunch hour, I'd like to thank all of our speakers again, and all of you for attending. And Suzanne, can I just ask, somebody had asked about slides. You're going to put the slides on the MICRA website. Is a recording going up as well, do you know?
Yes, the recording will be going up of the event.
Perfect, thank you.
Which will be later on this week.
And thank you for all of your comments and advice about the accessibility of the text and things like that. So we've made a note of that, and we'll feed back to the presenters of future seminars as well. Thank you all, and enjoy your lunch, and we'll see you all soon. Bye-bye.
Thank you for having me.